My name's Assembly Member Ron Kim. I'm the chair of the Assembly Standing Committee on Aging. I would like to open this hearing by welcoming all of you and thanking you for being here today. I want to also thank my program and counsel, Mr. Ben Decker, Maria McDermott, my staff, David Lee, Rachel Saperstein, for organizing this committee. I'm also joined by my good colleague, Jake Ashby. This might be your last assembly hearing. Congratulations on moving up. And we may be joined by other colleagues as well. According to a 2019 report from Center for an Urban Future, 16% of New York State's population is age 65 and older, and quickly becoming the fastest growing segment of the population statewide. As a result, it's increasingly important to ensure that New Yorkers have access to the resources, programs, and services they need to maintain so they can maintain their health and wellness and age in their homes. The committee seeks testimony today on the long-term needs of older adults who are not eligible for Medicaid, particularly the financial, economic, and social challenges these adults and their caregivers face in obtaining home-based long-term care services. During this hearing, we want to get into some specific reasons why so many older adults are falling through the cracks. Why is there such a big gap in how Medicaid home care are treated versus non-Medicaid home care attendants? As some of you know, recently in a privately arbitrated case, 42 licensed home care agencies were found guilty of wage theft based on Medicaid-based home care workers, as many continue to work under abusive 24-hour work shifts. To my knowledge, we don't see this type of abuse in non-Medicaid home care workforce, but at the same time, we have a long waiting list or unmet needs for services, and many older adults, instead of waiting, end up spending down to qualify for Medicaid. These are complex and complicated problems that are ultimately caused by not having universal fee-for-service long-term care and creating endless secondary and tertiary markets to manage the inefficiencies. But it's clear that if we fully fund and finance non-Medicaid home and community care, we will not only save hundreds of millions in Medicaid spending, but also prevent the widespread normalizing of exploitation of home care workers. Let me thank in advance all the witnesses for their participation in today's hearing, and to remind everyone to please limit their statements to 5 minutes. Before I call on the first witness to testify, let me turn it over to my colleague, Jake Ashby, if he wants to share a few words.
Thank you, Mr. Chairman. It's great to be with everybody today. I look forward to hearing the testimony of so many dedicated professionals involved in supporting our aging population here. And, you know, just in the last few months, we've been very busy trying to hear and listen about these issues that have been long-going systemic problems within our aging population and within the programming that the state offers. And I think it's time now to really put our best foot forward and take a hard look at this and look at ways that we can continue to expand access, yes, but also improve quality, because we're running into some pretty severe fiscal issues right now where we're going to have to make those decisions as best we can. And that's not possible without the input that we're going to be hearing today. So I look forward to the discussion. Thank you, Mr. Chairman.
Thank you, Mr. Ashby. Let me bring up our first witness, Ms. Rebecca Pree, Executive Director of the Association on Aging. Hey, Becky.
Good morning. I wanted to say initially thank you to Assemblyman Kim and soon-to-be Senator Mr. Ashby. You two have both been dedicated to the aging population for years, and the network really appreciates that. My name is Rebecca Prevey. I am the Executive Director of the Association on Aging in New York. We're a not-for-profit membership organization that represents the 59 offices for the aging, also known as area agencies on aging, across New York State. Our network leverages over 1,200 community-based organizations, and I'm here on behalf of this network to provide you information on the aging population and the impact of community-based services to older residents throughout the state. I'd like to begin by mentioning language is very important, and although my testimony today will focus on some of the needs of the older population, we need to recognize that having an older population should not be viewed in an ageist way. It should not be referenced as a silver tsunami or a tidal wave. 83% of national wealth is actually held by 50 plus, and having a robust aging population is an economic driver for New York State. Identifying bias is very important when considering the aging population and the services provided through the network. Our services through Office for the Aging are predicated on ensuring individuals can age in place with autonomy, dignity, self-direction, and respect. We provide a variety of programs and services referenced in my written testimony, but I would like to focus on our most impactful program for non-Medicaid long-term care services. Our home care services are part of Medicaid prevention, as we provide in-home services for individuals that do not qualify for Medicaid but cannot afford to privately pay the full cost of the services. This distinction is important as our services are proven to prevent future Medicaid costs, which includes a significant state share for skilled nursing facility placements. Our average in-home care client is an 83-year-old female who lives alone, is low income, has 4 or more chronic conditions, and needs assistance with basic activities of daily living, such as bathing, toileting, dressing, and meal preparation. These individuals typically qualify for nursing home placement or spend down to community Medicaid in order to access services. Our network knows from our own client data that 10% of individuals waiting for services go directly to a skilled nursing facility, and an additional 6% spend down to community Medicaid coverage. The state savings to Medicaid for the aging population served via the Aging Services Network is close to $70 million per year. We all know that New York State is 4th in the nation in the over 60 population. In addition, census data indicates that the fastest growing segment of the population are individuals over the age of 80. We know that the state's overall population is predicated to grow by 1.3% through 2040, but the 80 plus population will see growth of 42%. Additionally, 70% of the older population will need some form of home care during their lifetime, and home care services can prevent emergency department utilization and transition to skilled nursing facility care. New York State has announced the Master Plan on Aging and has instituted a division within Department of Health for Aging and Long-Term Care. We are all enthusiastic about the opportunity to ensure we are looking at aging as a lifelong process, not just starting at the age of 60. The master plans needs to address the impacts of prevention, education, accessibility of the built environment, and support care across a continuum from private pay to fully subsidized services. It also needs to ensure that all state government organizations are not working within silos, but are addressing policy changes to ensure we're an age-friendly state. We won't continue to be an age-friendly state or implement a successful master plan on aging without ensuring that the infrastructure created 4 decades ago has sufficient funding to maintain and enhance services. As you are aware, there's a rapidly growing aging population in conjunction with a significant rise in inflation, exacerbated by a pandemic that severely impacted older residents and increased demand for aging services by over 70%. We continue to see significant waiting lists for services. We're dealing with huge increases in costs of raw materials, significant workforce shortages, and increased customers. In addition to these issues, the state failed to support the Aging Services Network by completely excluding our staff from worker bonuses and failing to invest in home care services, even though we were mandated to provide the same $2 rate increase as of October 1st for direct care workers. It is important to note that federal stimulus dollars have supported the Aging Network over the course of the past 3 years, but these funds are not ongoing, and we have individuals that are dependent upon services today that need to be continued tomorrow. In order to maintain our current service infrastructure, we are looking for $7 million to address the mandated unfunded rate increase for home care workers. We are very, very excited that home care workers were given a raise on October 1 with an additional $1 October 1 of 2023, but we have to have the investment in order to cover this wage increase because we use the same licensed home care providers as the Medicaid system. We are also looking strictly for inflationary cost for goods and services, including our home delivered meals and case management services of a little over $29 million. Again, this calculation is for existing customers and adjusts us for current inflationary rates. Regarding our waiting lists, we are looking for $9.5 million to address non-personal care services. These are transportation, home-delivered meals, legal services, case management, et cetera. I wanted to very clearly show the legislature that we do have waiting lists for services based on funding that is not due to the direct care worker shortage. We are looking for about $30 million to actually subsidize our home care services program to authorize same levels as Medicaid. We currently provide about 5 hours per week versus the average Medicaid client of 10 hours per week. We're also looking for full funding for fair pay for home care to establish a base rate of 150% of regional minimum wage in order to make sure that we have a licensed home care agency to support our services. I want to thank all of you for your time and attention, and I really look forward to working with the legislature and the governor's office moving forward to support the older New Yorkers and their caregivers that we support.
Thank you so much, Becky, for your testimony today. So most of the non-Medicaid home and community care funding that is under the aegis of the State Office for Aging, this is, unlike the Department of Health, unlike Medicaid funding, this is mostly county-run, county partnerships that oversees the home and community care, correct?
Correct.
And can you just clarify then what is the difference in the payment structure on how the older adult funding streams through ISIP and other community grants are paid to the actual providers versus the Medicaid home care?
Sure, so we use a variety of funding. We use federal, state, and then county taxpayer dollars to fund our home care services program. And again, we serve individuals that are just above that income benchmark for Medicaid, but they can't afford to privately pay for the service. And what's unique about our infrastructure and what has been very successful for us is we actually directly contract with the licensed home care provider. There's no MLTC plan or middle management, it's a direct contract. Those individuals are also case managed, so any issue of fraud, waste, or abuse is addressed because the AAA is providing that supervisory role. I'd also like to highlight that obviously the home care worker shortage has impacted every sector from hospitals, skilled nursing facilities down to community-based care. What we've done in over 10 counties is to try to pilot an innovative program where we directly employ home health aides through the Offices for the Aging. Or we have an exclusive contract with a licensed home care agency for dedicated home health aides to go to our clients. The reason that's important is they become part of a care team and feel very ingrained with the Office for the Aging. And what we have seen is that these individuals either become county employees, so they have state benefits and retirement, plus they're getting paid a living wage. We have seen in the counties that have employed this practice a full implication for their waiting list to actually fill those cases. And that has been very, very successful for us to try and serve older individuals. And I think it's a model that the rest of the state needs to look at, especially regarding the home care worker shortage.
So in other words, you've helped counties activate public workforce to get back into the home care business.
Correct.
And it's been super effective because you were able to streamline public resources, I'm assuming, yes. And for instance, access to county transportation that many home care workers do not have when they're licensed individually. And so is the administrative capacity building that SOFA and counties have done around home care to start incrementally treat public care work as public service? This is I think, a fascinating, innovative model that could potentially really change the game for New York. Do you think we should be supporting more of this moving forward and trying to get counties to get back into the business of home care? Absolutely,
and I think the way our network is structured, we've addressed many of the issues that you hear from direct care workers. So it's very expensive to have a vehicle, to have, in weather like we have today, you need winter tires on your car. You might be driving extensive mileage in between cases. Being part of a county government structure with a dedicated home health aide, you have access to county transportation. You also, like I said, are part of that care team with a potential career ladder moving forward within county government. And you're also receiving a wage that makes you non-dependent on public benefits. So we know 50% of the direct care workforce is currently dependent upon public benefits, which is a cost to the taxpayer. So the model not only addresses the individuals that we're trying to provide care for, it also lifts the workforce up and increases economic revenue for the state of New York.
Are you aware of any non-Medicaid home care workers that have to take on 24-hour work shifts?
No, our network does not provide 24-hour authorizations.
Okay, thank you. Mr. Ashby?
Thank you, Mr. Chairman. Thank you, Becky. It's good to hear from you. Regarding this program, currently what counties are offering it?
So counties such as Putnam, Schoharie, Steuben, Columbia, Orleans, Cattaraugus, Wyoming, Otsego, Ontario, and Lewis.
So quite a few. And in terms of the geographic diversity of them, several of them I'm familiar with. They're pretty rural, and then others more suburban. Do you see a pretty consistent result throughout their efforts in terms of the improvement? Are there any pitfalls that you're seeing, potentially if it were picked up in more urban areas that we may have to look out for?
Not that we have identified. I can share with you that as of last week, I conducted our waitlist survey, and I asked all of the counties specifically if their waiting list for personal care services was due to the lack of home health aides. 100% of them indicated that it was. I can tell you in the counties that have developed and implemented this program, some have still struggled to get staff hired. It's a process to go through within county government, but the overwhelming feedback we have received that has been shared with the other AAA directors is that this is a model that absolutely works and it absolutely serves people. And an example in a local county, Putnam County, completely eliminated their waiting list by this practice. So I think it's something that's tried and true, and it's something that I think the Medicaid system could look at just from a wage and benefit analysis, which is why we support fair pay for home care, because it would get people off that benefits cliff and give them meaningful wages for the work that they do.
What do you see in terms of cost if counties start to pick up and adopt this program? Cost to the counties?
The cost is actually very similar to what we see through the contracting process, because again, we don't utilize MLTCs or Medicaid systems for that go-between. So most of the counties will pay, a range of hourly rate between $25 and $35 per hour to a licensed home care agency. So when they bring that in-house, they're able to absorb that cost. The other thing that we have seen is at times counties struggle to spend money dedicated for home care services because they don't have any aides available in their area. So this is a way to expend dollars that they do receive for the service.
If the staff isn't available, what we've seen in other settings in healthcare is that they have to go with agencies and travel programs. Is this something that this program is facing as well, this issue?
There are some times where an aide is not available to fill a case, but we don't see the prevalence that we see within other service systems. And like I said, because we're flat budgeted, we aren't able to go in. If I did an assessment in your home, Mr. Ashby, I can't go in and assess you based on need. I have to go based on the fact that I have a set budget to provide services to my entire county. So what could I give you that's going to help you in your home and community versus if I'm Medicaid funded, you get the hours based on your actual need. And again, that's why we're looking for an investment, because we need to be able to serve people equitably as the Medicaid program. Because as I said, and I've spoken to both of you about this, we're saving Medicaid dollars in the long term. So, we serve people in homes and communities on average for 6.5 years for less than $10,000 versus a nursing home placement downstate exceeding $150,000 per year.
Thank you.
Thank you. Ms. Ashby, just one more quick question, Becky. Unlike the Department of Health's Medicaid reimbursed home care, because the SOFA and non-Medicaid home care works directly hand-in-hand with counties and officials, we've also done, it's my understanding we've also done a better job at data collection and seeing the trends of where things are going. I'm wondering if you can speak to the impact of the economy at large when older adults spend down to qualify for Medicaid, and how does that impact the families and overall economy when more and more older adults start spending down to qualify for Medicaid instead of applying and getting the non-Medicaid services that's provided to them?
So I think there's many factors within that statement, and what we do know is people don't want to have to spend down to Medicaid. They don't want to have to impoverish themselves to receive a service. But again, if we don't have that preventive side, that's the only options for individuals. And that means a variety of different things. Either they're looking at higher level settings to receive care, whether it be assisted living or skilled nursing facility placement. It also brings them below a benchmark where they're contributing excessively to the economy at large. So goods and services being purchased. Again, when you're impoverished, you don't have money available to do so. So I think we look at aging through the Aging Services Network the same way I think many other agencies look at other positions in healthcare. So we know it's not good to smoke, so we work on smoking cessation programs. We also look at prevention within alcohol and substance abuse. You know, we get into high schools and talk to individuals about making sure that we're preventing ever needing those services. We don't talk enough about preventing having people spend down to Medicaid or institutional care. And that's really what we want the master plan to focus on, is aging is a lifelong process. How can we make sure that we're targeting people in their 30s with high blood pressure, because we know that that's going to impact Alzheimer's disease when they're in their later years. So it really needs to be a cohesive thought process to ensure that we allow individuals to age in place and that we keep them off Medicaid, because we know Medicaid is not sustainable at the current levels of spending.
Thank you so much, Rebecca, for your testimony today.
Thank you both.
I'm sorry, do you have any? You were good? Okay, next up, we have AARP, Beth Finkel, State Director, AARP New York.
Good morning. Good morning, Assemblymember Kim. You are an incredible champion for older adults. We work together on so many issues. I just want to personally thank you for all your work. And Assemblymember Ashby, looking forward to your next gig in the Senate and working with you there. So thank you so much for convening this meeting today. AARP has over 2.3 million members in New York State, and obviously how people age and how they can age in place is probably one of the most important areas that we work on. I feel like I'm here today because I'm able to echo a lot of what Becky has just already laid out to you. New Yorkers really want long-term care services, mostly in their home, and they have very definite opinions about how they want to receive that care and who they want to provide it to them. We all know going through COVID, people really don't want to go into nursing homes, even more so than ever before. And back to Becky's data points around it's under $10,000 to keep someone at home and over $150,000 to put them in institutional care. And Assemblymember Ashby, this goes back to your original point about impact on budget. It's really essential that we look at that because there are 2.5 million family caregivers in New York State, providing over 30 billion hours of care, but most importantly, over $30 billion in actual, if you had to go out and pay for that care, they're providing it for free. So we need to keep that system going because they are literally the backbone of our long-term care system, and without them in place and supported, you're going to have more people in institutional care, and all those concerns that you have rightfully so about budget will become even more important to know. We've been surveying our members for a long time, and we know that they want to stay at home. And we also know that when we look at New York's home care workers, they are 92% women, they are 81% people of color, and this is the one that just kills you. They receive median earnings of, are you ready, $19,000 a year. $19,000 a year. So now they are all dependent on our systems also of getting all the other benefits that they need to support themselves, because $19,000 is not going to support anybody, not even halfway. So we really think it's important that workers that the median age for home care workers in New York is now under $15 per hour, and nearly half of this workforce now lives near poverty. 57% rely on public assistance, and we wonder why we don't have more people in home care and why we have a shortage of home care workers. We recently released a survey exploring long-term care services. It's all in your reports. I'm not going to give you all the data points. I'll just hit the top one. Nearly 9 in 10 New York voters age 50 plus would prefer to receive long-term care at home with caregiving assistance if they or a loved one needs such care. So we need to really look at the struggle that the caregivers are providing after the data that I showed you before about how important their work is and how essential it is for our long-term care system. We need to look at transparency, who and who is not receiving home and community-based services. We hear about thousands of individuals statewide are waiting to receive non-Medicaid home and community-based services such as transportation, adult daycare, home-delivered meals, and respite. Thousands of these families continue to languish on these waiting lists. We need to make sure that we have transparency about these waiting lists, and as a matter of fact, we need to thank the Assembly, and I know you know about this, Assembly Member Kim, for passing the Assembly A2590, and the Senate was same as from Parker. For the last 2 years, that would create transparency that we are highlighting here today. We really need this so that SOFA can get the right numbers it needs, and that we, both the public and legislators, know exactly where these numbers are coming from so they can plan appropriately for it. We don't have that as of right now. We're really hoping that those bills pass again this year, and that this year they're finally signed by the governor so we really can see what the unmet need is. ARP recommends in the next state budget that it include an investment of at least $50 million as recommended by the Association on Aging, as I said before, because we have got to address these waiting lists. We also need to make sure that we have a very strong home care delivery system, because if we don't, then it's going to end up with that much more expensive taxpayer system that I know you're concerned about, and we are too. Finally, we really want to appreciate the work the legislature did last year to provide a $3 increase over 3 years, but ARP would argue that if money that you appropriated does not actually get to the home care agencies, what good does it do? So we really need to look at that. But with that said, ARP recommends S5374 May bill, same as 6329 Gottfried bill, to be revisited the next session and passed. And this one would provide reimbursement for home care workers at 150% of the regional minimum wage. So finally, Master Plan on Aging, we're all very excited about it. It has huge potential, but we have to make sure that we hold state government feet to the fire on this, and that they deliver exactly what they have promised in terms of really looking at how people can age here in New York, how we can keep them here in New York, so that in the end they don't take their pensions and their Social Security and everything else and leave for other states. Interestingly enough, the data we did recently, we found out #1 state is Pennsylvania. So that I thought that was pretty interesting. So, although we know about Florida. So I want to thank you all very much for giving us this opportunity to testify for our 2.3 million members here in New York State. And thank you so much for convening this. It's so important.
Thank you so much, Beth, for your testimony today. And also thank you, ARP, for getting behind the Grieving Families Act and encouraging the governor to sign the legislation without any amendments. I think it would be a game-changing legislation to amend the wrongful death statute to properly capture the traumatic and emotional damages that often do not get factored in. It would change, I think, the nursing home and hospital and all the industries to be better toward older adults. So thank you for that advocacy. Let's go back to the Master Plan on Aging for a minute.
Sure.
How has the administration been in engaging the community groups? I know that I think we've had our first meeting now under the governor's executive order. Are you feeling optimistic that we're taking steps in the right direction?
I think the best part of the executive order is that it literally puts in dates that things have to be delivered by. So 60 days from the signing the executive order, they have to have it up and running. So we know it was right before the election that it was announced. So the clock is ticking. We're 30 days, a little more than 30 days out right now. So that's why that first meeting was important. So that was the meeting of the departments that are going to be the basic part of that master plan. The next part is they have to appoint the stakeholder group and they have to get convened. And then from that point forward, you have 18 months to pull together all the recommendations and get it all in motion. So we're excited. The timeline, I think, is a terrific timeline. I believe that they will stick to it. We have not heard who's going to be appointed to that task force yet, the stakeholder group, so we're waiting to hear that, and then we'll be off and running. But there's a lot of opportunity. We know that, they're looking particularly at Department of Health, Medicaid, long-term care, but we want to make sure that we're covering all the pieces of age-friendly. New York State was the first age-friendly state in the country. We're all very, very proud of that. And now we need to make good on those 8 domains of age-friendly to make sure that it's about all of those pieces so that, again, as I said before, people remain in New York, and they, Becky was talking about percentage, I know you did too, about older New Yorkers and the economic driver that they are, but they're also the capital driver of New York. Personal capital, right? Volunteer capital. We all know who volunteers at every, center in New York, churches, synagogues, YMCAs, etc., hospitals. It's older New Yorkers.
Yeah, and I would certainly hope that as we move forward, as you've echoed in this testimony, that the home community care piece do not get lost or treated as a distant cousin to institutionalized care, because that's often how the state has treated care for so many decades, and I hope that we can seize this plan to really rethink and redesign, reimagine what care should look like, starting from home and community care. But I think the incentives from the outside markets that rely on so much money for institutionalized care versus the $9,000, $10,000 that we can spend to fund a functional home care puts a lot of pressure on Albany to continue to prioritize institutionalized care, but we all know that's not the answer. And I hope that ARP will continue to be a strong advocate inside the administration when you get that seat on the table.
Well, just one more point. You're right, because they have been taken for granted. And what happens is when you take people for granted for that long, you burn them out. And you burn them out, and then the cost to all of our institutions in New York is going to be huge. So we better take care of it before we hit that precipice, because then there's no going back.
Great.
Thank you.
Becky, thank you so much for your testimony.